Podcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today we are going to discuss about cardiovascular physiology part 2. In this episode, we are going to cover mainly the cardiac cycle. So Maddi, can you please describe the cardiovascular events that occur during ventricular systole and diastole?
So the cardiac cycle is made up of two phases defined by the mechanical activity of cardiac muscles. Systole, which is ventricular contraction, which lasts about 300 milliseconds, and diastole, which is ventricular relaxation and lasts about 500 milliseconds. The cardiovascular events that occur during these two phases can be subdivided into mechanical and electrochemical events. We'll first start with ventricular systole. In terms of the mechanical events, ventricular systole consists of isovolumetric contraction and ventricular ejection. Within isovolumetric contraction, this is the beginning of ventricular systole, where the atrioventricular valves close. This is heard as the first heart sound, and the intraventricular pressure rises rapidly. This rise in pressure causes the atrioventricular valves to bulge into the atria, causing a small rise in atrial pressure, which corresponds to the C wave in the CVP trace. Isovolumetric contraction lasts about 50 milliseconds until the pressure in the left and the right ventricles exceed the pressure in the aorta, which is about 80 millimeters of mercury, and the pulmonary artery, which is about 10 millimeters of mercury, respectively. This causes opening of the aortic and pulmonary valves, which marks the beginning of ventricular ejection. There is no change in the volume of blood within the ventricles during this stage, hence it's termed isovolumetric contraction. The second phase of ventricular systole is ventricular ejection. This consists of an early rapid ejection phase lasting around 100 milliseconds, where about 70% of stroke volume is ejected, and a prolonged reduced ejection phase lasting about 150 milliseconds, where the remaining 30% is ejected. Intraventricular pressure rises to a maximum of about 120 millimeters of mercury in the left ventricle and 25 millimeters of mercury in the right ventricle. Atrial pressure initially reduces to zero during rapid ejection as the atrioventricular ring is pulled downwards by ventricular contraction. This is seen on the CVP trace as the X descent. Atrial pressure then begins to rise as atrial volume increases, and this is seen as the V wave, which occurs in late systole/early diastole. Approximately 70 to 90 mils of blood is ejected by each ventricle during each cardiac cycle. There is about 50 mils of blood remaining in each ventricle at the end of systole, otherwise known as the end systolic volume. Ventricular ejection ends when the aortic and the pulmonary valve close, heard as the second heart sound. In terms of the electrochemical events that occur during ventricular systole, the R wave of the ECG occurs at the beginning of isovolumetric contraction, and the T wave marks the end of ventricular systole and the start of isovolumetric relaxation. Phase 0, 1, 2, and 3 of the cardiac action potential occurs during ventricular systole. Phase 0 is caused by the opening of fast sodium channels, which causes ventricular depolarization and marks the beginning of ventricular systole. Phase 1, where there is closure of the fast sodium channels and opening of transient outward potassium channels. Phase 2, where there is opening of long-type calcium channels, which is balanced by potassium efflux through delayed rectifier potassium channels. And Phase 3, where there is closure of the L-type calcium channels, resulting in unopposed potassium efflux and repolarization. Phase 3 marks the end of ventricular systole and the beginning of ventricular diastole. Now, coming to ventricular diastole, there are mechanical and electrochemical events. The mechanical events consist of isovolumetric relaxation and ventricular filling. Isovolumetric relaxation marks the beginning of diastole and occurs after the closure of the aortic and pulmonary valves, which is responsible for the dichrotic notch. This lasts about 30 to 60 milliseconds. The ventricular myocytes relax and the intraventricular pressure reduces rapidly, but both the semilunar and the atrioventricular valves are closed, meaning the volume within the ventricles remains constant. Atrial pressure rises to about 2 millimeters of mercury in the right atrium and 5 millimeters of mercury in the left atrium. During ventricular filling, this is the phase where the pressure within the ventricles fall below atrial pressure, resulting in opening of the atrioventricular valve. There is a period of rapid filling, which lasts for about 100 milliseconds and corresponds to the wide descent on the CVP trace. This is followed by a slow filling stage, or ventricular diastasis, which lasts 200 milliseconds. During this stage, the intraventricular pressure has risen, which reduces the pressure gradient between the atria and the ventricles, thus reducing the rate of filling. The final stage is atrial contraction, or atrial systole, which lasts about 100 milliseconds and corresponds to the A wave on the CVP trace. During the rapid filling stage, about 75% of ventricular filling occurs. Only 5% occurs during ventricular diastasis, and about 20% occurs during atrial systole. At the end of diastole, there is approximately 120 to 130 mils of blood within the ventricles, otherwise known as the end diastolic volume. During ventricular filling, atrial pressure is slightly higher than ventricular pressure, and aortic and pulmonary pressures decrease as blood moves from the vasculature to the heart. When ventricular pressure rises above atrial pressure, the mitral and tricuspid valves close, marking the beginning of ventricular systole. In terms of the electrochemical events that occur during ventricular diastole, the P wave on the ECG represents atrial depolarization and corresponds to atrial systole. The Q wave occurs at the end of ventricular diastole and represents the beginning of ventricular depolarization. Diastole corresponds to phase 4 of the cardiac myocyte action potential, which is maintained by inward rectifier potassium channels in non-pacemaker cells.
Thanks, Maddi. So I guess when you write this answer in exam, you need to draw a neat label diagram, and all the diagrams related to this answer will be available in the show notes on the website critcareedu.com.au. So make sure that when you're listening to podcasts, you also access the website. Now, let's dive deeper into one of the very crucial concepts of cardiovascular physiology, that is Frank-Starling Mechanism. So can you please describe the Frank-Starling Mechanism and its relationship to excitation contraction coupling?
The Frank-Starling mechanism states that energy of contraction is proportional to the initial length of myocardial fibers. In the heart, this length of myocardial fibers is related to the end diastolic volume. Therefore, up to a point, the force of contraction, or the stroke volume, is increased by increasing venous return, or preload. At a certain point, though, any increase in preload will exceed the heart's contractile ability and result in no change or even a decrease in stroke volume. Excitation contraction coupling is the process by which an action potential results in a mechanical response, which in this case is myocardial contraction followed by relaxation. An action potential spreads over the muscle cell membrane and down the T-tubule system, causing L-type calcium channel opening and calcium influx. This influx triggers release of calcium from the sarcoplasmic reticulum through ryanodine receptors, which causes a large increase in intracellular calcium concentration. The calcium then binds to troponin C, causing a conformational change in tropomyosin, so that a part of the actin molecule is exposed. This allows the head of myosin molecules to bind, leading to ATP hydrolysis, cross-bridging of the actin and myosin, and sliding of thick-on-thin filaments, causing muscle contraction. Increasing preload increases the sarcomere length, which increases troponin C calcium sensitivity. This increases the rate of cross-bridge attachment and detachment and the amount of tension developed by the muscle fiber, thus increasing contractility. Increasing preload also optimizes the overlap of actin and myosin and maximizes cross-bridge formation, thus increasing contractility.
Great. So often we ask this question when we get a patient in shock that what's patient's cardiac output. So can you please define cardiac output?
Cardiac output is the volume of blood ejected by the heart per unit time and is the heart rate multiplied by the stroke volume. Normal cardiac output is usually between 4 to 8 litres per minute. In terms of the factors within cardiac output, stroke volume is governed by preload, afterload, and contractility. It is important to note that these main determinants of cardiac output, that is heart rate, stroke, and stroke volume, can influence each other. Due to the Frank-Starling mechanism, cardiac output under normal, unstressed conditions is altered mainly by factors affecting the peripheral circulation and venous return.
Great. And what are those factors that affect heart rate, preload, afterload, and contractility?
So let's first think about heart rate. So heart rate is affected by multiple factors, including autonomic influences, as the heart rate is normally controlled by the SA node, which is heavily influenced by vagal tone. Parasympathetic stimulation decreases heart rate, while sympathetic stimulation increases heart rate. Heart rate is also affected by hormones such as thyroid hormones and catecholamines, increased levels of which cause an increased heart rate. It is also affected by body temperature, so in conditions of hypothermia, this can cause an increased heart rate. And there are reflexes that affect heart rate, including the Bainbridge reflex, where increased right atrial pressure causes increased heart rate due to stimulation of atrial stretch receptors, and the baroreceptor reflex, where changes in blood pressure are detected by aortic and carotid baroreceptors, and a decrease in blood pressure will increase the sympathetic nerve activity, which increases heart rate. Age and sex also have an influence on heart rate, where heart rate is generally faster in females and those of a younger age, such as babies, and slower in males and as age increases. And numerous drugs can impact heart rate, for example, beta blockers, which can reduce heart rate. Now turning to preload. Preload is the myocardial sarcomere length just prior to contraction. Surrogate measures of preload are left ventricular end diastolic pressure or volume. Preload is influenced by venous return, where the mean systemic filling pressure, which is the average pressure within the circulation if there was no cardiac activity, the difference between this pressure, the mean systemic filling pressure, and right atrial pressure is the gradient for venous return. The normal mean systemic filling pressure is about 7 millimeters of mercury and increases with increased venomotor tone or blood volume. Any increase in venous return generally increases preload. Therefore, any increase in mean systemic filling pressure, such as with increased blood volume, or any decrease in mean right atrial pressure, such as with negative intrathoracic pressure, will increase venous return. Other determinants of preload include heart rate, where slower heart rates allow for greater diastolic time and therefore greater filling time in preload. Atrial contractile force also influences preload. As we've described earlier, the atrial kick or systole gives ventricles approximately 20% of their end diastolic volume. Therefore, loss of this atrial kick, such as in atrial fibrillation, reduces preload. Other things that influence preload include ventricular or pericardial compliance. Increased ventricular compliance will increase filling for a given pressure and therefore increase preload. Decreased pericardial compliance, such as due to a large effusion, will decrease ventricular filling and therefore decrease preload. Another influence of preload is valvular integrity. For example, with atrioventricular valvular stenosis, that will result in reduced ventricular filling and therefore reduced preload. Now turning to afterload. Afterload is a tension which needs to be generated in cardiac muscle before shortening will occur, or put another way, it's a load against which the heart must eject blood. It is equal to ventricular wall stress, which can be described using the law of Laplace, where ventricular wall stress equals ventricular transmural pressure times the radius, all divided by 2 times the wall thickness. Therefore, afterload can be thought of in terms of these components. Ventricular transmural pressure is a difference between intraventricular pressure and pleural pressure. Intraventricular pressure is affected by outflow tract impedance and pulmonary or systemic vascular resistance. Any increase in outflow tract impedance, such as with aortic or pulmonary stenosis or with hypertrophic cardiac myopathy, will increase afterload. When we think about systemic or pulmonary vascular resistance, this can be determined by the modified Hagen-Purcell equation, where resistance equals 8 times viscosity times vessel length divided by pi multiplied by the vessel radius to the power of 4. Therefore, any increase in the viscosity or the vessel length or any decrease in the radius will increase vascular resistance, and any increase in vascular resistance will increase afterload. This is the mechanism of action of numerous drugs which affect afterload by altering vascular resistance. Another factor is arterial compliance, where any decrease in arterial compliance will increase afterload. And finally, any increase in pleural pressure, such as with positive pressure ventilation, will decrease ventricular transmural pressure, so will decrease left ventricular afterload. Now, when we think about the law of Laplace, any increase in ventricular radius will increase end diastolic volume, so afterload will increase. And any increase in ventricular wall thickness will decrease afterload. Coming to contractility, this is the intrinsic ability of myocardial fibers to shorten. It is influenced by the amount of intracellular calcium, with increased intracellular calcium causing increased inotropy or contractility. Determinants of contractility include autonomic influences, where sympathetic stimulation increases contractility while parasympathetic stimulation decreases contractility. Other influences include the Bowditch effect, where contractility improves at faster heart rates, and the ANREP effect, where myocardial contractility increases with increased afterload. Hormonal and metabolic factors can increase contractility, with things like thyroid hormones, catecholamines, calcium, and glucagon increasing contractility, while hypoxia, acidosis, and hyperkalemia decrease contractility. And finally, there are numerous pharmacological factors which can increase or decrease contractility, such as ones we use in ICU, with positive inotropes such as milrinone and negative inotropes such as calcium channel blockers.
Now, you mentioned about the afterload, and there are certain drugs in ICU that we use specifically to increase afterload, such as vasopressors like noradrenaline or metreminol. Now, say, just consider a hypothetical scenario when accidentally someone gives a big bolus of these drugs. What are the cardiovascular effects of sudden increase in afterload?
Initially, there'll be a decrease in the left atrial pressure and an increase in the end systolic volume, which causes a decrease in stroke volume. However, in a healthy heart, this will lead to a secondary increase in end diastolic volume, and thus some increase in preload and increased contractility by the Frank-Starling mechanism. There is also a small increase in contractility via the ANREP mechanism, which we mentioned earlier. In terms of cardiac output, an increase in afterload may reduce cardiac output depending on the extent of the afterload increase and the health of the heart. In a normal healthy heart, an increase in afterload can usually be compensated for to some extent by increasing preload and contractility. A sudden increase in afterload will also increase the ventricular end systolic and end diastolic pressure and will increase the myocardial oxygen demand and myocardial work. As coronary blood flow is autoregulated, the coronary blood flow will increase as it is tightly coupled to oxygen demand, and an increased afterload increases oxygen demand. The systemic blood pressure will increase, and the stretch caused by this increased afterload will increase the firing from baroreceptors, resulting in an inhibition of sympathetic drive and increased vagal tone in an attempt to reduce blood pressure.
Okay. Now, the fundamental to cardiovascular physiology is maintaining the myocardial oxygen demand versus supply. So can you please briefly outline the the determinants of myocardial oxygen demand?
Normal myocardial oxygen consumption is very high at approximately 8 to 10 mils per 100 grams per minute. In the previous episode, we discussed the fact that the heart has a very high oxygen extraction ratio and the mechanisms by which it regulates blood flow to facilitate this high oxygen demand. The three major determinants of myocardial oxygen consumption are myocardial wall stress, heart rate, and contractility. As we mentioned earlier, myocardial wall stress is determined by the law of Laplace, where stress equals transmural pressure times radius divided by 2 times the wall thickness. Any increase in myocardial wall stress or tension will increase oxygen demand. Increased heart rate also increases oxygen demand, as does increased contractility. There are a few minor determinants of myocardial oxygen demand, which include the basal metabolic rate, the external work performed, and the energy for electrical activation. External work performed is the energy expended to eject blood from the ventricle, which is otherwise known as volume work. And the energy for electrical activation is very small in myocardium, only requiring about 0.7 mils of oxygen per minute per 100 grams of myocardial tissue.
Thanks, Maddi. So again, as I mentioned before, all the diagrams related to this podcast will be available as a show notes on the website www.critcareedu.com.au. Now, I also run the Facebook page called as Critical Care Education, where I post different polls, podcasts, and all critical care education related information. And one of the comments from our diehard fan of this podcast, Dr. Adam Jackson, he gave a big compliment to your joke. In fact, he said that he remembers the joke more than the podcast, which is a bit concerning for me. However, he said he's looking forward to next joke. So obviously, I'm pretty sure you're not going to disappoint him. So do you have any questions for me today?
Yes, I do. So how did neurologists increase their cardiac output?
Oh my goodness, neurologist and cardiac output. I think by walking to CT scanner.
No, by increasing their stroke volume.
Great, that's a good question, Maddi. Thanks.
I have to thank my husband. He came up with that one.
Oh, and I think he's sitting his exam, so all the best, Jules. And I think he's contributing to this podcast as well. Thank you very much. So thanks, Maddi. Thanks, folks. So that's the end of our podcast on cardiovascular physiology part 2. We'll be back with another episode on cardiovascular physiology in month's time. And Maddi is going to go on holidays soon. So wish you a very happy journey and pleasant time.
Thanks very much.
And we'll see you in 1 month's time. Till then, goodbye.
Thanks for listening. See you next time.